Hello, my name is Marvin Malik. I'm course director for the Northern New England Health Policy Internship Program. And today's session, we'll be looking at the Medicare program and uh, as well as its sister program, the privatized version of Medicare called Medicare Advantage. And without further ado, we'll share some slides. As you heard about in the previous talk from a few days ago, the health insurance situation in the United States by the 1950s included fairly prevalent private health insurance coverage for employees. Uh, Maybe half the employees in the country who were employees of wealthier, larger companies. But most of the rest of the country, most poor people and elderly did not have any coverage. And in 1962, Michael Harrington wrote a highly publicized book called The Other America, that there were 40 or 50 million socially invisible Americans, low wages, living in poverty within what seemed to be an increasingly affluent society. And many of these people, really most of them, had minimal health coverage. In 1964, 50% of the elderly had no insurance coverage for hospitalization, and a quarter of seniors would go without health care due to unaffordability. So during the late 50s and early 60s, there were a variety of social movements. The most widely known these days is the civil rights movement. But there were others, many others, and one of them was the movement for healthcare justice, to allow the poor and elderly people who worked for small employers to actually get coverage. So there was a struggle both on the streets and in the legislatures across the country and in Washington. And finally, with a progressive legislature and Kennedy followed by Lyndon Johnson in office, they, with some of the progressive legislation of 1965, Voting Rights Act, Civil Rights Act, and other pieces of legislation, really important initiatives were the Medicare and Medicaid programs. The Medicaid program was for the poor. We'll discuss that subsequently in a different talk. Today's topic is Medicare, which was the coverage primarily for the elderly. Uh, Unions uh, required a lot of, I'm sorry, senior citizens required a lot of hospital care. And even though the labor unions were not supporting single-payer universal health care at that point, they did strongly support Medicare legislation that would cover their parents. And gradually there were various legislative proposals for coverage for the elderly. And finally, the Lyndon Johnson signed the Medicare legislation into law in 1965. Notice who's sitting next to him. That's Harry Truman, who had fought for a single-payer universal health care program, but was thwarted largely by propaganda campaign funded by the American Medical Association at the time. But The compromise to cover the elderly and the poor in separate pieces of legislation was what resulted from the various social movements and and lobbyists. And Harry Truman was the first person who signed up. And within 6 months, over 96% of the elderly had already signed up for the program, despite no computer, no computerization at all. Simple postcard said, I want the coverage, and most everybody did. So, in traditional Medicare, which is what was passed in 1965, you go to the doctor, you show them your Medicare card, and Medicare would pay your doctor. Pretty simple. Program had very low administrative costs. The benefit package included, we'll ignore Medicare Advantage, which had not existed at the time. So it included hospital inpatient services, which is a big expense, 21% of the program. Outpatient prescription drugs covered later. There was no drug coverage initially. Hospital outpatient services like going to the hospital to get an x-ray or a blood test, and then going to the doctor or going to a physical therapist. So these were all going to be covered, though not including the prescription drugs yet. Home health was covered, and there was a very limited skilled nursing home benefit, only covering nursing home care when it followed a significant hospitalization. So Part A covered inpatient services, except for a category called observation, which I won't discuss at this time. Outpatient, Part B covers outpatient services, physician visits, lab, x-rays, chemotherapy infusions, physical therapy, all the outpatient stuff. And nowadays it covers a lot of surgery that can be done in an outpatient setting where the patient does not need to sleep in the hospital. And we'll talk a little later about the pharmaceutical benefit added in 2003. And Part C, which was added 20 years after the program started in the 1980s, um, uh, was the privatized version of Medicare. So what you notice here is that between 2011 and projected spending in 2031, there's an ever smaller percentage of Medicare spending will be on hospital care, and more of it will be on outpatient spending, which is in the blue in this diagram. And then the pharmacy costs as a percentage of the overall program stay around 11 or 12%, not changing that much through the period. And worthy of note is that Medicare coverage has always been inadequate. And it exposes people to the potential of bankruptcy, primarily because the poor quality of the Part B outpatient benefit. Part A coverage for people who've been citizens for a long time and worked for more than 10 years. Part A coverage for the hospital is really good, with very little copayment or other out-of-pocket cost. Part B is a whole nother story. 20% outpatient coinsurance is the biggest problem. And that means for every $100 that you're going to spend on a lab test or an x-ray on a doctor visit, Medicare B was going to cover 80% and you pay the other 20% out of pocket. And imagine getting chemotherapy where the drug itself costs $100,000 plus a year. That means just that drug would cost you $20,000 a year. So that's a huge problem. There is a hospital deductible for people who haven't worked full time for 10 years. And importantly, as you're paying that 20% outpatient coinsurance, there's not going to be a limit. You can just keep paying it. If you have three chemotherapy drugs, the other ones cost another $200,000, you're going to pay another 40,000. There's just no limit at all. There's no ceiling on out of pocket, potential out of pocket coverage. So you can do nothing about it and risk bankruptcy, or the other option is to purchase a supplement plan. And right away in 1965, when the program passed, these immediately started to be offered. And by 1966, a substantial portion of the Medicare population had already elected to purchase these plans, which at the time were not that expensive. Nowadays, they're up to $2,000 or so a year. So that was what was available then. And so, as I said, this Medicare's gotten really expensive as healthcare costs in the US have risen. And for the last year for which data is available, which is 2024, if you just take total Medicare spending, divide that by the number of beneficiaries, it's $17,786 is the portion that the government pays. The beneficiaries are averaging around $7,000 a year between paying all these premiums, out-of-pocket expenses, dental care, vision care, hearing aids, all kinds of expenses, Tylenol if they have, and other kinds of things, inserts if they need that in their footwear. So for this compares to private health insurance for the people under 65, and the employer cost per individual coverage is $5,700. The premium cost to the workers just under $1,200. So you can see that there's a lot of payment both for people over and under 65 years old in the US currently. And as I said, so the total cost to the worker is around $5,547 when you add in all the co-pays, deductibles, and this is really rising fast. So this will be outdated and go up quite a bit, especially for people under 65. So as I said, Medicare needs improvement, and one way to measure this is that if you look at people in different income groups, for people who are at less than 100% of poverty, these are impoverished people, um, so 38.7% of them in the year 2016 paid more than 20% of their income on all the costs that were entailed. For people in the 100 to 150% of poverty group, they're paying 41% of them paid more than 20% of their income. Not much better for the people between 150 and 200% of poverty. They're also paying 40%. Even going all the way up to the 200 to 400% of poverty group, they're paying 22.5% of their income on healthcare too. So coverage is not great for senior citizens in terms of how much they can afford to spend. It's only when you get to more than 400% of poverty that the available coverage through Medicare makes it so that only 6% of them are spending more than 20% of their income. Another feature of Medicare, the Medicare program in the US, is that it's a massive, centralized, unaccountable bureaucracy that, from the point of view of many doctors, feels very, very out of touch and has a lot of regulation that a lot of which seems unjustified. Not all of it, but it's not a model of a program that's user-friendly, that welcomes input from really either patients or hospitals and doctors. And during our discussion section, I can give you some examples of that. But a Medicare, one of the biggest things it needs is to make it an accountable program. And that would probably place second after making it affordable for the people it's supposed to be serving. Um, so the distribution, let me go back here. The So as I already said, Medicare coverage is poor, and so virtually everyone wants to have additional coverage. So for those people who have purchased supplemental coverage, back in in 2016, 30% of those Medicare beneficiaries um, who were not in a Medicare Advantage plan, just had regular Medicare, 30% of them had retiree health coverage through their employer. And I am interested to see updated data because that percentage is really dropping. And retiree health coverage is now available primarily to government employees, and it's a declining percentage of those. Maybe some people who work for insurance companies or very wealthy companies, but that's becoming a dinosaur. 30% of the population who has original Medicare are paying for supplemental coverage themselves. That percentage is increasing. And then 22% are poor and poor enough to qualify for the Medicaid program. And then back in 2016, 19% of people in traditional Medicare had no supplemental coverage of any kind. So they were exposed to unlimited out-of-pocket costs. However, there's another program which we're going to discuss in a little while, which is the privatized version of Medicare. And that's been growing as a share of the total up to passing 50% around 2022, half the enrollees. So let's give some history on that. So the Medicare began in 1965, as I said, and in 1982, which is early in the Reagan administration, in response to some insurance industry lobbyists, the CMS, which is the agency that runs Medicare and Medicaid, they created a program in which they would make a fixed monthly payment to a private plan. And that private plan becomes responsible to fund all medically necessary care that would be included in the benefit. So, for example, at that time, there was no drug benefit, so that would not be included in these private plans. But everything that Medicare, regular old Medicare would pay for, the Medicare Advantage plans were responsible for those types of care that Medicare would pay for. So again, why did this happen? And here's the real reason. In 1965, private insurance companies were actually happy to let government pay for care of the two most medically expensive groups, the elderly and the poor. The elderly because they're getting old and they're accumulating chronic illnesses, and the poor because one of the big reasons people are poor is because they're not healthy and they can't work and do all the for example, if they'd had a head injury, they probably are not going to qualify for the jobs that pay the best. So they're going to be poor and they're expensive if they've got a major chronic health problem. So the private insurers were happy to let the government take care of them. However, over the subsequent 20 years, the market they did have penetration in, which was Americans under age 65, the percentage and overall gross numbers of Americans who were covered was not growing. It was stagnating. This is because health costs were rising, and the businesses like gas stations or mom and pop stores, they couldn't afford to provide health coverage in 1965, and nothing happened in the subsequent 20 years that made it so they could afford it. So the insurance industry was not growing, and many of the insurance companies are sold on the stock market and have investors, and they expect some growth in their investments. So during the 1970s and 80s, the private insurance companies' strategic planning teams rethought their strategy about the poor and elderly, and they began to develop strategies that would allow them to make profit if they did cover these sicker populations. And the big attraction was that while the owner of a convenience store may not have a whole lot of money, they're selling things at a small margin for the most part. Um, Uncle Sam wasn't that way. The Treasury can go into deficit and carry debt, carry a deficit. And so they decided to rethink their approach toward the Medicare and Medicaid programs and maybe find a way to get some of that money that Uncle Sam was now paying for Medicare and Medicaid. And there was an ideological side to this as well. So on the one hand, the lobbyists from the insurance industry wanted in on that money, but at the same time, Reagan and the kind of neoliberal philosophy that he uh, represented in the United States. Here he is at his very first inaugural address. Government is not the solution to our problems. Government is the problem. So with that philosophy, you can see why privatization was what someone with that philosophy would turn to. So the program, this privatization scheme within Medicare, it was initially called Medicare Plus Choice. Regulations were developed, and there was a formal launch of the program in 1985, and they called it then Medicare Part C. 12 years later, it got rebranded as Medicare Plus Choice. Ultimately, in 2003, they changed the name yet again to Medicare Advantage. It's all the same program. It's a privatized version of Medicare. And in the diagram, you can see that the government, the agency that runs Medicare, CMS, representing the taxpayers, now no longer pays the doctor directly, but instead there's a middleman inserted, and that's these insurance companies. So, and I'll just say the theory at the time was that the private sector was so much more efficient than the federal government that the federal government would save money. And it's worthy of note that there's not been a single year out of the last 40 in which Medicare did not lose money. Every year, the Medicare Trust Fund and the federal government lose money on the privatization scheme, currently Medicare Advantage. So the way they initially did the payment was participating insurers got 95% of the federal spending for the average Medicare beneficiary. They began to adjust for age, so an 80-year-old would be probably more expensive than a 70-year-old. So in 1997, they began to pay more based on age. So you would think the government might save money on the program if they're paying only 95%. But as we learned yesterday in the session on the insurance industry, the insurance industry was not intending to get a random sampling of Medicare beneficiaries into their program. They had no intention of recruiting in nursing homes or finding ways to cover the sickest elderly people. They were going to cover the people who were healthier. So they never advertised in people to people who needed chronic care, even though there are ways to reach those people and their families. On the other hand, they would advertise on the business pages of the Wall Street Journal because to anyone who would read the business page of the Wall Street Journal was likely wealthy, and so wealth correlates really highly with health status. And it meant that the person can read. In Medicare, not all beneficiaries can read. Those who can't are probably sicker, and they would understand what they've read. So just by that one test of trying to recruit people who can read a newspaper, especially the part of the newspaper that rich people would tend to read, you can see that they're going to already have a skewed population. They'll tend to make money. In 2003, the Medicare Prescription Drug Improvement and Modernization Act passed and was signed into law by President George W. Bush. So the reason they called it modernization is because most private health insurance by that time had begun to cover prescription drugs and preventive care. And for no particularly good reason, preventive care was not included back in the original benefit in 1965. And so finally, they were going to cover mammography screening and vaccines and other preventive care measures. And they also, at that time, is when they gave Medicare the privatization scheme. They started calling it Medicare Advantage. And they changed the payment system because they knew they were being ripped off with this 95% deal. So now they were going to risk adjust so that if the Medicare Advantage plans were selectively recruiting people who were not as sick, they would then get paid less. So this was going to protect the government from losing money on the Medicare Advantage, this privatized version of Medicare. So that was the hope. And the main impact of this bill was to cover drugs, prescription drugs. Medicare B had already covered chemotherapy infusions and any drug that was given as part of a hospitalization. But now it was going to cover outpatient drugs, the stuff you buy yourself in a pharmacy. But the drug benefit was to be administered by dozens of private health insurance companies. So if there's dozens of private health insurance companies participating, over 40 to be exact, then none of them were going to have market power to negotiate with the drug companies to get the prices down. So in order to do that, they would end up doing the same thing that insurance companies for younger people did, which is to rely on pharmacy benefit managers, which actually don't reduce drug spending. We're going to discuss that in depth at the final week of this internship program. At any rate, what they specifically prohibited was the federal government negotiating to get drug prices down. The federal government, if it covered everybody, could negotiate down prices for all 340 million Americans, but that was prohibited within Medicare in this bill. And of course, the government doesn't do it for people under 65 either. So the drug industry had lobbied hard for that clause and they got it. The benefit structure was actually initially pretty complicated. You paid $250 deductible or something like that, and then 25% of the cost until you got to $2,250 of total spending in that year out of pocket, at which point the drug benefit paid nothing. And then if you got up to something like $3,500, then the drug benefit paid 95%. So it's kind of a complicated, problematic benefit structure, and why they were penalizing people whose spending fell into the range of 2,200 to 3,500. Nobody had a good answer to that. Finally, that was changed about 6 or 8 years ago or something like that, or something like that. And now you pay 25% until you get to $2,100, at which point the government takes over. So now it's a more generous benefit, more costly to the federal government, And it's also a lot simpler currently. But that was how the bill was passed. Okay, so within a year of that program passing, the vendors began marketing software to to uh, game this coding system that was supposed to accomplish risk adjustment. So, as I said a few minutes ago, Medicare's new payment system, which is called the hierarchical condition coding system, was going to somehow make it so that plans that picked off healthy people were going to get paid less. So, um, software vendors started marketing software to game this, picking out the details of each code and got pretty good at that. And we'll look at the impact of that in just a few minutes. And another part of this act was that the new Medicare Advantage plans could provide extra benefits if they had enough money to do that. This might attract, more enrollees. So let me get back in. So we'll look at that in just a minute. So here is a list of the benefits they were allowed to provide, these Medicare Advantage plans, ranging from telemonitoring, bathroom safety like grab bars or a shower chair, in-home support workers, transportation to medical appointments, meals, over-the-counter drugs, dental care, hearing aids, uh, fitness center stipend, and eyeglasses. So which benefits do you suspect that the Medicare Advantage plans did and did not provide? Well, you're right. They almost all provided fitness center stipends, eyeglasses, hearing aids, and dental care. Those, of course, are the types of services that a lot of people need, even if they're really healthy. And then some of them provided over-the-counter drugs, which a lot of people use, or dental, or Meals on Wheels or transportation to medical appointments. But when you're starting to lose transportation, because figuring that people who can drive a car are probably healthier, so people who can't may be less healthy, so they mostly don't provide that one. And then there's caregiver support, bathroom safety, an in-home worker, and telemonitoring for people with advanced heart disease. So they didn't want to go near any of those because you can imagine who would want those benefits. So this is kind of how the thing broke down. And then you can think of it as a marketing tool. They want healthy people, so they tell them, we'll cover your next pair of eyeglasses and a dental checkup. Come to us. And this healthy person could not care that they're not giving caregiver support. So this was all a marketing scheme that really the federal government opened up for them and did nothing to immediately prevent it from being abused just right away. So Medicare Advantage continues to grow as they are really good at doing things that will attract healthy people. That allows them to lower the premiums to get into the program, and more people enroll. Lower premiums than the Medicare supplemental plans. And the market share, this one is heavily two companies, United Healthcare and Humana. And then if you throw in Blue Cross and Aetna, which is part of CVS, you're almost to three-quarters. So, and four CEOs control three-quarters of Medicare program. Okay, so if you look at revenue by category of product, the health insurance companies provide private health coverage to employee groups and private individuals. And you can see that between 2010 and 21, that decade, there's no growth. There really hasn't been much growth in the private insurance market since 1965. It's been stagnating. And there's Medicare. So this scheme that they developed in the 1980s to see if they could make money off Medicare, this is the most rapidly growing part of their revenue. And if you throw in Medicaid, which they've also tried to privatize with success, that's growing too. So digging into the government's pocket has been a very lucrative strategy for the health insurance companies. Now, what's the business model for Medicare Advantage? And it's really the same three methods that all businesses have to use or think about. And that's to maximize revenue per patient or per interaction, minimize expenses, which in this case would be actual patient care, and then increase the total number of people who are in your program. So increase the volume, increase the revenue per individual in that volume, and then cut your expenses. So let's look at how they do that. So you can increase the volume through intense advertising, and you probably have seen ads if you're picking out the stations that cater to the elderly. Joe Namath, this great New York Jets quarterback from the 1970s, he's getting old now, and he's hawking Medicare Advantage plans for this insurance broker. And the Medicare Advantage companies pay insurance brokers extra to enroll people in Medicare. So they really want to do that. When you go to an insurance broker, you're not going to get objective information. It's going to be biased because they get paid about twice as much. For example, in California, they paid over $700 by the Medicare Advantage companies to enroll a new person onto their Medicare Advantage plan, and only half of that to enroll a person into a Medicare supplemental plan. So they highlight the low premiums to get into the program and the extra benefits, dental and vision stuff, hearing aids. They never mention the copays, the narrow network, prior authorization. That's not discussed, or the payment denials. Okay, so next step, maximize the revenues per Medicare patient. So strategy one, increase the number of people who sign up. That's we already heard about. So maximize revenues so that now your revenues are primarily determined by what the federal government's going to pay you. So the scheme that they use to pay Medicare Advantage plans is ridiculous. It's completely arcane. It's very difficult to understand, and it's heavily dependent on what's going on, who the beneficiaries are for the patients who don't elect to get into a Medicare Advantage plan. It's a strange formula, and they are also paid for quality of care, which I'll talk about in a second. So they lobby the federal government for high benchmark payments. And just to give you another example of what they do, their lobbyists did such a good job with when hospice became one of the Medicare benefits, which it had been for several years. If you enroll in a Medicare Advantage program, then you enroll in hospice because you have cancer or some really bad disease that makes it likely you won't live 6 months. Instead of the Medicare Advantage company paying for your hospice benefit, which costs $208 a day, regardless of how many days you're in the program, regardless of what services you need, the geniuses who formulated this program decided that the traditional Medicare would pay for the hospice benefit for people enrolled in Medicare Advantage programs. In other words, at the very same time, Medicare was paying the full price to the hospice provider of over $200 a day. They were still paying the Medicare Advantage companies, and they get about $1,600 a month. And so it's a real scheme, you could also call it a scam, a real achievement of highly effective lobbying. So for the average person in hospice, the average enrollee is in for 87 days, and that will save the Medicare Advantage company $17,400. So that was a good deal for them. Now, we'll talk now about upcoding and risk score gaming. So I mentioned that very quickly after the reimbursement scheme was changed in 2003, implemented in 2006, this new hierarchical condition coding system. What what it does is it pays extra if you've got a lot of big diseases, and the scheme pays less if you're totally healthy. So what this gaming does is they take advantage of every little nook and cranny in the coding system for the hundreds and hundreds of diagnoses that exist in the index book of every single, which includes every single medical diagnosis that's ever been discovered. Um, they for example, there might be heart failure, systolic, diastolic, class 3. Um, and it could be refractory, to treatment or something. So the details of the coding system really matter. So they'll find little schemes within the coding system to boost their payment. So we'll take a look at that. So because the risk scores are driving reimbursement, let's just look at a healthy 76-year-old. At 76, they get 0.45 points in this coding system. And if they have no extra codes, they're pretty healthy. They're gonna end up, I think, with something like $9,000. I'm sorry, $4,000 a year. The year this was created in 2019, this graph and this little expose, the average person in Medicare would cost about $8,000. But if your risk score was really low, which this one would be, that um, this CMS, I'm sorry, this patient is going to get the insurance company $4,000. Now, here's a more typical patient, somebody who's got some diagnoses. At 76 years old, they get the 0.45 we already discussed. Obesity gets them nothing. Type 2 diabetes coded as such gets them 0.104. Major depression, nothing. Congestive heart failure, 0.323. Asthma, nothing. An unspecified cutaneous ulcer gets them nothing. And there's an interaction code because people with heart failure with diabetes, the cost of their care is even a little higher for either condition alone. Anyway, so that all added up to a score of 1.03, which gets the insurer about $9,000. Okay, so now let's take the software that's going to play around with this and see if they can do a little better. So they're going to take this patient in the middle, in the row here that we just talked about, and he's still 76 years old, so that's staying at 0.45. But now suddenly he's got morbid obesity instead of just obesity. That adds on 0.273. He's got really mild changes of very early retinopathy, but that adds 0.318, so that's adding quite a bit onto what their type 2 diabetes had without that little bit of retinopathy. And this time, instead of just the general code major depression, if you say that it's a single episode and it's mild, that gets you 0.395. And don't ask me why this would get you more than just plain old major depression. I did not invent this coding system. And then there's heart failure, class 3. That actually did not get him much more. That must be the average code. So that's 0.323 again. And now instead of calling it asthma, they're calling this obstructive lung disease chronic obstructive lung disease, which turns out not to be especially easy to differentiate from asthma. So by coding it that way, you get 0.328 added on. And that's an easy one to just kind of add on. And if you then take that cutaneous ulcer and stage it, and it's stage 3, that gets you 1.2 more. And then there's a triple interaction code with heart failure, diabetes, and COPD. So this is all going to add up now. And this little scheme with this software that maximizes your reimbursement, this got the risk score up to 3.63, and the very same patient that was otherwise going to get the insurer $9,000 is now getting the insurer $32,000. So this software is worth the price if they're going to do this to every single patient. And they do. Every single patient is coded to the maximum possible. And the gradation of what this is called upcoding, where you make a person look sicker than than they actually are. The borderline between what's actually legal and what's kind of pushing it a little too far to call it legal is pretty gray. So there's lots and lots of cheating going on, and the Medicare Advantage Inspector General has repeatedly put out reports talking about this cheating. Okay, so there's an incessant search for more codes. Then there's home care visits and an annual wellness exam. And in both of these cases, the the doctor is encouraged to come up with more diagnoses. And the home care visits, which the insurance company is allowed to provide, often they'll send a nurse to the insurance company will send their own nurse, not part of the regional visiting nurses association. They'll send their own nurse to try to come up with more diagnoses to enter into the patient's record to allow the company to get paid more. So they're really, going all out in maximizing reimbursement by making patients appear to be ill. They data mine electronic health records, and there's software to help with that. And then optimizing the initial set of codes we already talked about. And the final strategy is a direct financial incentive to primary care providers. And so the more they can kind of control what primary care providers do by paying them a kickback, or imagine if they actually employ them, they could really change the reimbursement scheme. So anyway, that would be another way to try to get more codes out of this, out of each patient. So Medicare Advantage plans get paid also for quality of care, while providers who take care of patients who did not get into a Medicare Advantage but stayed in traditional Medicare, they get paid nothing even if they provide the best quality of care. So this is federal taxpayer money only going to Medicare Advantage plans. And this is not budget neutral. They get paid for having what's called a star rating. This is the quality assessment system. If the star rating is 4 or 5, they get paid more. And they don't lose if their star rating is poor. It'll be published and they may lose enrollees in the subsequent year, but this is a total upside game. They don't lose any money out of the scoring system. And certain Medicare Advantage companies have consistently maintained higher star ratings, and these are the largest companies tend to have the best star ratings. Companies with deep financial resources, dedicated data tracking infrastructure, and experience in the program, and they know how to milk the system. And what you can see, this graph shows um, that by enrollment, the 4 and 5 star ratings were done by companies that together cover about 85% of the Medicare Advantage population, but those plans only represent about 55% or 60% of all the enrollees. So you can see that so in other words, these are the large plans that are getting the 5 star rating because they're deep enough to kind of game the system and do what they need to do to get those scores. So since this is a lot of money to get the high ratings, 4 and 5, when they don't get rated high, they get out their legal team. And so Humana is refiling a Medicare Advantage ratings lawsuit. Alignment Healthcare, another Medicare Advantage company, sues CMS over their star rating, alleging wrongful scores. And in general, in the year this was in, which was actually last year, the Medicare Advantage companies were trying to lose their lawsuits about the rating system. Here's a winner, Clover, another health Medicare Advantage plan. They won their case in theirs. And here's Elevance, a very large private health insurance company, for profit and publicly traded on Wall Street, and they've got enough money to challenge their star rating. So this is now a whole part of the scheme. This is a high stakes quality measurement. We're going to talk more about that next week. High stakes quality monitoring. So the net of this is that Medicare overpays Medicare Advantage plans with its benchmark system, which is almost designed to overpay them. Risk adjustments, the cheating, the quality incentives, it's all there. So when they get overpaid, what do they do with the money? These Medicare Advantage plans, they improve their benefits, lower premiums, add dental and hearing aid coverage. They can spend money on upcoding software to even, code even more cleverly, spend more money on advertising, or increase their dividends to their stockholders. Now, the final strategy, so they've tried to attract the most people to get the highest reimbursement per person. And now the final strategy is to minimize the amount of money they spend. And this is a major focus that they have as well. So in traditional Medicare, 98% of the money that goes through traditional Medicare goes to doctors and hospitals, only 2% to overhead. It's a different story in Medicare Advantage. They're legally required to spend at least 85% of each dollar they take in on providing care. And that, in other words, they're allowed to keep 15% for overhead and profits, and that's about what it ends up being. So as I mentioned earlier, 1982 was the first subcontracting scheme to a private plan, and the requirement was there would be the Medicare trust fund would make a fixed monthly payment to a private plan, which is responsible to fund all medically necessary care. That sounded like that words medically necessary were just kind of bureaucratic speak, but those two words turned out to be pretty important. And you can guess who decides what's medically necessary. Is it going to be the doctors or is it going to be the insurance company? And your answer to that question is correct. It's on the right. The insurance company gets to decide what's medically necessary. So they deny all kinds of care. They deny care that's already been provided, especially emergency department care and hospital care. They look at the record and they say, oh, that patient could have been in Hoag. You didn't need to admit him. This is now they're denying care on someone they've never met, never examined. The people who deny the care do not have a medical degree for the most part. And that's what goes on. The doctor thought they needed to be in the hospital. The patient couldn't walk or whatever it was, but they just deny. The other way to deny is before the test or treatment even happens. That's called prior authorization. And so that the Inspector General studied that back in 2022, and they found that about 18% of denials were unjustified and 13% of prior authorization denials raised concerns about beneficiary access to medically necessary care. Just last week or last month, rather, the Inspector General issued another report indicating that over 50% of referrals for post-hospital rehab are being denied, and that the largest Medicare Advantage companies, United Healthcare and Humana being two, they actually denied the highest percentage. So they're up in the 60-70% range they deny. One insurance company, I don't recall which, denied 90% of requests for rehab care. Now you got to remember, these are patients who went into the hospital. They're already not in great physical shape. They get pneumonia and just starting to walk by the final hospital day to regain some strength. And then they're denied. They need supervised rehab in a skilled facility where there's people to keep the patient from falling and helping them to get moving again. And do they have the right kind of walker? Are they using it properly before they're discharged back home? So this is denied routinely almost by these Medicare Advantage companies, alleging that, well, that could be done at home. And when I thought about this because I work as a hospitalist, and it seemed to me that 100% of rehab requests were being denied. And what's not mentioned in this report, though, is that literally 100% are delayed because they always take 3 days to even begin to engage and consider what they're going to do. So I've never yet seen a decision come back in less than 3 days. Whereas a patient in traditional Medicare, if we say that patient is now pretty much through the stage of their illness where they need to be in the hospital, now they just need physical strengthening and skilled physical therapy, they're ready to go to rehab. They go that day for the most part, sometimes waiting a day or two if the right rehab bed is not available. On the other hand, minimum 3 day wait for these if they're in a Medicare Advantage plan. And the reason why is because in the hospital, the Medicare Advantage corporation is paying, once there's a diagnosis, they pay a fixed amount. So in other words, if I treat a patient with right lower lobe pneumonia in the hospital, and the patient's in a Medicare Advantage plan, they get a fixed amount of money, no matter if I keep the patient in the hospital for 10 days. On the other hand, when they go to rehab, they pay by the day. So they want that patient to be, once they got a certain diagnosis, they want them in the hospital right until they're ready to go home. And that's what's generating all these denials. And these companies are militant about it. So, another strategy to discourage care is to make the patient pay for a lot of the bill. So co-payments are required for most everything. And this is not the case if you're in regular old Medicare with a Medigap plan. Anyway, so co-payments are required for everything, least so often a vaccine will be free, a primary care visit won't cost much. But if you start going to specialists and getting MRI studies, you're going to pay. And the annual out-of-pocket payment is $8,300, but that's only if you stay in the plan's network. If you stray out of the network, they can make you pay up to $12,000, and that's in 2025. And I think that's going up this next year, what they're allowed to make the patient pay. So they have networks of doctors that are they considered in network and that they want the patients to go to. In the network, they're going to pay the doctors who are in the hospitals in the network a little less. So that's the ones they want the patient to go to. So narrow networks restrict the number of doctors and hospitals, often to only less than half the providers in the metro area. And between all these issues, denials of care and narrow networks, 27% of patients who disenroll from a Medicare Advantage plan get back into regular Medicare. They did it because they just couldn't get the care they needed, and not from the doctors they wanted to go to. And they preferred providers who were not in network, and many of them said that as well. And if they want to go to a top-ranked cancer hospital for their cancer surgery, if you're in a Medicare Advantage, you're a lot less likely to end up in a cancer hospital. And then, so the next question is, each year, people are allowed to get into Medicare or to leave Medicare and get into Medicare Advantage or out of Medicare Advantage. There's a period each year in the autumn when you decide which plan you want, whether it's a Medigap plan or whether it's going to be a Medicare Advantage plan. And so people go back and forth each year to some extent. So among patients who had um, no nursing home stay, what you're seeing here is patients who leave traditional Medicare to get into a Medicare Advantage plan. The same percentage leave regardless of whether they had a long-term nursing home stay or not. On the other hand, for people who want to get out of Medicare Advantage, they're way more likely to be in the group that has had a long-term nursing home stay. So these are the people who are really frail and probably have lots of illnesses, and they're really likely to want to get out of Medicare Advantage. And for short-term stays, it's in between. So now so far we've talked about people enrolling into Medicare based on they chose it because the premiums are so much lower than they are for a Medigap plan. But now there's an increasing number of people who are being enrolled in Medicare Advantage plans that they did not choose. And this is called a group-based Medicare Advantage plan. And what's going on here? These are the people who have retiree health coverage. And it could be that their union or their employer is responsible for administering the benefit of this retiree health coverage benefit. So instead of just paying for a Medicare supplemental plan and leaving them in traditional Medicare, increasingly they're getting their retirees enrolled in Medicare Advantage plans, a group plan. And CMS, the government, pays the Medicare Advantage uh, organization a capitated payment, and the union or the employer, the former employer, can add on benefits if they want to, like better prescription drug coverage or whatever, but they're now in a Medicare Advantage plan. So, in other words, on the left is the original system. The employer would buy a supplemental plan that would cover whatever Medicare didn't, and Medicare would remain the primary payer. But in this new situation, they're now the employer or the union that's administering the retiree coverage is selecting a Medicare Advantage plan. It does all the things we just mentioned a little earlier. So now out of all the people in Medicare, this was, I think, 2025. 17% of people in a Medicare Advantage plan were enrolled in it without choosing it. They were retirees. And these two graphs, the graph on the the upper graph shows the total number of people who were shoved into Medicare Advantage plans by their employer. These are people with retiree health coverage being shoved into Medicare Advantage. And you can see that just from 2010 to 25, that's tripled from 2 million people to 6 million. And then this graph just shows that overall large firms, a decreasing percentage of large firms are actually offering any retiree benefits. So this retiree health coverage as a whole is declining, but among those who have it, they're increasingly being shoved into Medicare Advantage plans, and they don't like it. So in New York City, there was when it's actually a union that administers their retiree health benefits, and they wanted to save money, so they contacted a Medicare Advantage plan, and they had it all set up. But then suddenly there were all these demonstrations and lawsuits, and the retirees, I believe that's over with now, and the retirees from New York City's municipal government, I think they won, and they're not going to be enrolled in the Medicare Advantage plans that was looming. Same thing happened in Vermont. I was actually asked to speak about Medicare Advantage business model to people, retirees who were part of the Public Employees Union, and yeah, they filed a lawsuit and they won as well. The teachers here in Vermont didn't do as well. Their contract was weaker, so they have been shoved into a Medicare Advantage plan. Okay, so funding of Medicare, sorry, funding of Medicare, Part A is funded through payroll tax. So on every paycheck you get it, there's a little deduction for FICA. That money's going to Social Security and Medicare Part A. On the other hand, Part B and Part D, the drug benefit, they're both funded through general revenue. Now, for somebody in original Medicare, when they go to the doctor, the Medicare pays a certain amount of money to the doctor in the hospital. And it actually takes an act of Congress to update that payment rate, even if there's been a lot of general inflation or medical inflation. It literally takes an act of Congress to provide a pay increase just for reflecting the cost of living or any other reason. On the other hand, the annual modifications to Medicare Advantage payments, there's a formula that's legislated, but it's really complicated. And the federal agency that administers Medicare, that's CMS, they have a whole lot of discretion in setting payment rates. And they have been really generous to Medicare Advantage plans right up to 2023. And I don't know what happened in 2023, but suddenly the Biden administration said, well, actually, we've been overpaying since 2007 every single year. I mean, people who watched this knew that, but suddenly they discovered it. Okay, so they tried to do something about it, but that generated a whole lobbying campaign by the main lobby, which is called the Better Medicare Alliance, that pulled out all the stops with Congress, and the lobby got more than half of what was threatened restored. So it was kind of a truce. They were still giving it annual increases greater than what the doctors in original Medicare were getting, but it's not a good situation. Trump has actually tried to stand up to this, but he has given in a long ways as well. Okay, so in contrast to all the limitations on care that you saw in Medicare Advantage plan, if you have traditional Medicare with a supplemental plan, you can go to any primary care provider, most all of them except Medicare, for the most part, or a specialist office or a hospital. There's no permission needing, no prior authorization. There's no out-of-pocket expense for the most part, no surprise bills, and the patient can therefore trust it will actually be there when she needs the coverage. And that those supplemental plans cost about $2,000 annually. And the drug benefit costs around uh, $400 a year, 400 to 500 for the most part. So you're paying $2,500 a year to have a supplemental plan plus a Part D drug plan. And in contrast, the Medicare Advantage system is complicated, inefficient. It certainly has lower premiums to get the supplemental coverage. Is much cheaper in Medicare Advantage. It's about 20% of what you'd pay. In other words, around $400 a year rather than 2,000 to get into a Medicare Advantage plan. But then, if you actually need care, you don't have co-pays or co-insurance to speak of if you're in traditional Medicare with a gap plan. Whereas in a Medicare Advantage plan, the more esoteric the services, the more you pay, especially if you don't like their providers. So it's a lot more complicated, how the whole Medicare Advantage scheme works. High overhead, high profits. They try to find healthy people and make them look sick through their coding system. And what it's done is it's turned traditional Medicare into a high-risk pool so that the expensive people don't like the narrow networks or the denials of care, so they get themselves back over to a regular Medicare plan when they really need care. Okay, so let's take a few cases. Jeanette L. is a charming, well-organized 78-year-old. She's been very healthy over the years, little forgetful, but she remembered to get all her vaccines anyway. She gets along quite well with her primary care doctor, never forgets her only medicine, a pill to lower her blood pressure. It works well. It's a generic drug, doesn't cost her much. And she likes the fact that her Medicare Advantage plan sends her reminders to refill her prescription and get her vaccines on schedule. She's impressed. So she's in her Medicare Advantage plan. She likes it. Fred is an 86-year-old guy with heart disease. He had first heart attack culminated in bypass surgery. His out-of-pocket spending is really high with specialty visits, a lot of blood testing to make sure his kidney function and potassium level are in the proper range. And after his second hospitalization of the current year, he was really weak, and his physical therapist at the hospital said he definitely needed rehab. So this is the kind of guy whose Medicare Advantage plans are not going to be thrilled about, and they may deny enough of what we're talking about here so that he may opt out of Medicare Advantage the following year when the open enrollment period comes up. Here's another patient, 69-year-old woman, has had multiple sclerosis for years. Her neurologist is actually in network, but she's not doing well. She spent a lot of money on x-rays in her Medicare Advantage plan, MRI studies, lab tests, bunch of medication. She spent the maximum out of pocket in her in-network limit for each of the last 3 years, $8,300 out of pocket each year. However, due to advancing disease, her neurologist wants her to go to a subspecialist in Boston. So again, that's not going to go well. The plan doesn't, finds her to be a pretty expensive deal. And whether they'll let her go to Boston is, pretty unlikely. Anyway, so that's another patient who may well opt out of Medicare Advantage. And here's Harry. He's the Medicare Advantage company's dream. A 60-year-old myopic marathon runner, hard of hearing, joins a plan, Medicare Advantage plan, in which he has benefit for both his hearing aid and his glasses, which is all he needs. So he gets his glasses and hearing aids with a minimal copay because he got covered through his plan. And then he He's running and he was training for a marathon, got hit by a truck and he died. And he was still in the Medicare Advantage plan. So think about this guy. They really scored on Harry because he never really cost them much of anything. And there's nothing that they like more than if you gotta die, then make it sudden death, so there's not a lot of spending in a final couple of hospitalizations. So Harry's the dream. And it's not just that the company will really benefit from him. He won't have any reason to believe that this insurance company is not wonderful because they gave him his glasses and his hearing aid. And, maybe he goes to a fitness center too, and they might be give him a little money for that. So if you do a survey, which they do, Harry's vote will count as much as somebody who's really had to use the plan, even though Harry hardly used it at all. So, this is real life people who interact in different ways with Medicare Advantage companies, and they make more profit, way more profit on some more than others. And the patient satisfaction correlates pretty highly with how little they use the plan. Okay, so thank you for your attention. And if you have any questions, we'll take them up in a subsequent session. Thank you so much. And that'll be it for today's program. Again, questions we'll deal with tomorrow. Thank you so much.